Good evening, and welcome to yet another COVID-19 Conversations. This is session 22, and we'll be talking about infertility this evening. As usual, your co-moderators are myself, Dr. Maya Williams, and Dr. Alison Myers. The latest COVID-19 stats, there are a total of over 29 million cases. On average, there are 114.8 cases, and the total number of deaths so far is over 500,000. The COVID-19 vaccinations in the United States, over 147 million vaccines have been delivered. Over 113 million vaccines have been administered. The total number of individuals vaccinated at least one dose is 22.2%, and fully vaccinated is at least 12%. We could see that the total number of COVID-19 cases by variants is increasing. The first variant, which is the B.1.1.7, is the number of reported cases is close to 5,000. The B.1.351 is 142, and the P1 is 27. There was a very interesting piece in the New York Times by Dr. Rhea Boyd talking about Black people need better vaccine access, not better vaccine attitudes. So there has been talk going around that Black people are vaccine hesitant. They do not want to take the vaccine because of the mistrust. But actually what's going on is that there are not many access to individuals or for Black people to have access to the vaccines. On our last COVID-19 conversations, we spoke about the barriers or the inequalities that existed, such as there will, in terms of for people with low English proficiency, there are not that many, in other languages, whether that be Spanish or Hindu or something along those lines. We also have Black Hispanic Americans lack in COVID-19 vaccination as outreach efforts struggle. And that is the same thing that we were speaking about earlier, that individuals, Black and brown individuals, do not have access to vaccines. There's not many outreach efforts. We have spoken about that a million times. Sometimes we have to go in our communities, such as in the barber shops, in the hair salons. Sometimes we have to even go into our ministries, into our churches to actually reach Black and Hispanic people, because we know that Black people trust their barbers. We know that we trust our pastors, and so those individuals can actually reach us. Today, our conversation will be on fibroids and Black women. Black women are 3 to 5 times more likely to develop fibroids than white women. In terms of endometriosis and Black women, there are distinct disparities in the diagnosis of endometriosis among women of different ethnic and racial origins. The authors of this article comment on the possible reasons for these disparities and the importance of recognizing them. And today we'll be speaking a little bit more about endometriosis and Black women. The causes of infertility signs and symptoms. The symptoms of female infertility, they're often asymptomatic. And you know that sometimes when you have fibroids, sometimes you don't necessarily have symptoms. And sometimes if you do have symptoms, the fibroid symptoms, you usually have heavy or painful periods. And sometimes for female infertility, there's also irregular or absent periods. Symptoms of male infertility, often without symptoms, erectile or ejaculation issues, and testicular pain. Signs of female infertility: abnormal hormone levels, blocked fallopian tubes, positive STD screening. Signs of male infertility: abnormal hormone levels, abnormal semen analysis, and atypical testicular biopsy. Fertility and COVID-19 vaccine, there has been a lot of talk around that because pregnant women were not in the clinical trials that were done for the vaccines. And so medical experts continue to assert that COVID-19 vaccines do not impact fertility. That means for a woman, if you have intentions of getting pregnant, then it is okay. It is safe for you to be able to take the COVID-19 vaccine. We'd like to thank our Day One audience members, the Department of Medicine and Trial, Constance Hill, and the Community Health Staten Island Hospital. You can continue to follow us at Minority Health 3 on Twitter and minorityhealth.convos on Instagram. We will be joined this evening once again by the lovely coach, Jessie Thompson. You guys can remember her from our January show when we did New Year, New Hope. She's a health coach, a nutritionist, and founder of the Detox Now. We also have joining us Dr. Tia Jackson Bay. She's a reproductive endocrinologist and infertility specialist, reproductive medicine associates at the Reproductive Medicine Associates of New York. She's also an assistant professor at the Icahn School of Medicine at Mount Sinai. And last but certainly not least, we have also joining us is Dr. Stephanie Thompson, who is also a reproductive endocrinologist and infertility specialist at the Institute of Reproductive Medicine and Science, IRMS, and the Department of Obstetrics and Gynecology at St. Barnaby Medical Center. I'll now hand it over to my co-moderator, Dr. Alison Myers, to start asking the questions.
Good evening, everybody. Looking forward to another wonderful show. So today we'll be talking about a topic that's probably near and dear to most of us, and that is going to be infertility. Unfortunately, about 9% of males in this country and 11% of females in this country are dealing with infertility. And when we look at couples in terms of infertility, we notice that 1/3 of the couples, the problem is the man, 1/3 is the female, and 1/3 is unknown. And we also know that 1 in 4 couples in the developing countries are dealing with infertility. So today with us, we have a couple of people to further explore this topic. So I'm going to first start with Jessie. Can you tell us what your journey is? You refer to your lovely daughter, Nia, as your miracle baby. Can you please tell us what your journey has been in dealing with infertility? Thank you.
Good evening, and thank you so much for having me. Just to make sure I did hit the button. Yes, I did. I am one of the, 90, up to 80, 90% of Black women who battle fibroids by age 50. And my fibroids were actually caused by infertility. I'm sorry, my fibroids actually caused infertility. And I battled the fibroids for 14 years, and 10 of those years I fought to actually have, yes, our miracle daughter, Nia Thompson. And what we found is, I ended up having a miscarriage. I ended up having 5 IVF cycles. I call it my $1 million journey because 5 IVF cycles, if anybody knows, I know our reproductive endocrinologists know what I'm talking about when I say cha-ching. And then more than 150 plus days in the hospital, 10 surgeries, 5 specific before having my daughter, 5 specifically for fibroids, which were 3 myomectomies, a UAE. And then after that, I ended up having a hysterectomy. And then 5 surgeries were for complications from the fibroid surgeries, which ended up in 5 additional small bowel surgeries, to where now I have a long-term condition, which makes me at high risk for COVID-19. Well, the coronavirus, excuse me, is short bowel, short gut. So when I fast forward, my daughter was born, miracle, my heart stopped on the operating table. It was crazy, but I am one of the ones that, in spite of all of the health inequities and everything going on, I did make it through. My daughter did make it through, and I'm very grateful. But that specifically birthed me into an awareness because Essence Magazine published my story in a story called My Fertility Journey. And it talked about how, with every IVF round, the fibroids came back, and I was literally either having an IVF procedure or I was having a fibroid procedure. And when my story came forth, I literally it went viral. And it brought on a deluge of stories from everywhere. People saying, oh my God, I'm on my 3rd myomectomy. I'm in my 5th IVF cycle, 2nd, all dealing with those same 2 major issues that are connected. Not every fibroid person dealing with fibroids deals with infertility, but it is one of the leading causes of infertility. And really that sparked an awareness for myself, because I didn't realize that it was a pandemic. I really thought it was my own personal hell. And I became an activist, specifically looking to advocate for patients. And really that sparked me into the work of, I like to say, when I birthed my daughter, she birthed me into the work of being a nutritionist, a health coach, I'm an author and now founder of an online wellness platform called thedetoxnow.com, where we really help people specifically to navigate the hurdles to help prevent dealing with holistic, what I called medical practices, such as we call them lifestyle medicine practices, such as trauma healing, stress management, nutritional coaching, as well as herbal supplements and daily practices to help prevent and even reverse these conditions holistically and even in an integrated way when we need to partner, of course, with their practitioners. And we've had amazing success. And I thank God, because I really believe we need to have an integrated team to help us be aware of everything that we have at our disposal to help advance our health and optimize our health outcomes.
So thank you for being so candid about your journey. That sounds like you went through a lot to get your miracle baby. And unfortunately, there's so many other women dealing with this. And according to the University of Michigan Health Labs, nearly 1/4 of Black women between the ages of 18 and 30 have fibroids, compared to about 6% of white women. And according to some national estimates, by the time we're at 35 as Black women, that number increases to 60%. Black women are also 2 to 3 times more likely to have recurring fibroids or suffer from complications. Why does this disparity exist, Dr. Thompson, and how exactly do fibroids impact fertility, as Jessie just explained?
Great. Thank you, Dr. Myers. Good evening, everybody. Really happy to be here. And, I am so excited that Coach Jessie was here sharing her story. It's really a great segue to fibroids and infertility and why is this happening and what's the best way to deal with it. So, first of all, fibroids are probably one of the most understudied areas of women's medicine and women's fertility. And of course, it's disproportionately affects us as Black women, right? We always see a little trend here sometimes. So, with that being said, some of the data on fibroids is really just not great. We think that fibroids are caused probably by a genetic component, but we really don't have a good answer for why fibroids are caused. And I'll tell you guys, just for those of you who aren't quite aware, what they really are fibroids are overgrowths, they're benign, of the muscle layer of the uterus. And so they can cause symptoms like pelvic pain, they can cause infertility depending on their location, constipation, all kinds of issues. So, we don't have a great identifiable cause for them, but it's thought that Black women might be more genetically susceptible to fibroids. And we are actually looking at entire genomic profiles now and coding genes for African-American women versus women of other descent to see if there's perhaps a specific gene that they can find for fibroids. And with that, it's very possible that we may actually, be able to find a rationale and cause for that. Fibroids themselves are very common, and many people don't know or will never ever find out that they have them unless they have an ultrasound or unless they have some symptoms. When it comes to fertility, not all fibroids are created equal, and we can talk about that a little bit more. And that's why it's so important to start care early and have a conversation with your doc. Right? If you go in for an exam, and you're in your 20s, you can say, hey, do you see any fibroids on my ultrasound? And just start to have that conversation early on.
Thank you. And as a follow-up, another condition that I would like to highlight, especially this is March, this is National Endometriosis Month. Endometriosis is another condition that impacts our community, another condition that we don't often talk about. And it sounds like a big part of the problem is it's not really well diagnosed. So it says that we as Black women, there was a study recently done, we're 51% less likely to be diagnosed compared to white women. But if we were Asian, interestingly enough, Asian women tend to be more diagnosed than anybody. So can you explain what is endometriosis and how does that also impact fertility?
Sure. So endometriosis, again, is another condition with multiple theories as to why it happens. But the most common theory is that what happens is the cells of the inner layer of your uterus, instead of coming out every month for you to have a period, actually go back into your abdomen through your fallopian tubes. And they can cause implants of that uterine tissue on your fallopian tubes, which are essential for fertility, on your ovaries and in your abdomen. And I can tell you why endometriosis is underdiagnosed in Black women. It is classic teaching in medical school that endometriosis is, to be quite frank, a white woman's condition. And it is true, there is more prevalence of endometriosis in Caucasian women, also with a possible genetic component. And I think this really speaks to health disparities in education as well, in medical education, because what we see, and we're not taught to necessarily think outside the box, is we put Black women in the fibroids category because they're more prevalent, and we put white women in the endometriosis category because it's more prevalent. And that is right away why you're going to have an underdiagnosis of endometriosis in the Black community. As practitioners, it's outside of your radar. You know, same concept as why maternal mortality is high. I read today that in the state of New Jersey, you're 7 times more likely to die as a Black woman in childbirth. So imagine that's a life or death situation, and now just the trickle down effect of what happens while you're trying to have your pain worked up and you're trying to figure it out. So I 100% believe that study. And I think it's important that, again, as we learn more about this and we stop doing this putting everyone in a box in medicine, then we're able to think and diagnose people for what they really have, looking at the conditions, but not necessarily looking at people's racial backgrounds. I mean, to give you guys another great example of this, for many years, we talked about cystic fibrosis as being more prevalent in the white community and sickle cell being more prevalent in the Black community. But as we start to do widespread genetic testing, we are all mixed up. So, we're doing these genetic screening panels and we're finding that, again, our ethnicity-based screening is no longer ideal, and that trickles down into reproductive medicine.
Thank you. And so back to you, Coach Jessie. You've become a health coach to help women who are experiencing these conditions, fibroids and endometriosis. What is the role of a health coach? And for people on here who are interested in becoming one, who might have been in your shoes, how do you go about doing that?
Sure. So number one, the role of the health coach is to help provide accountability, community, and support for the patient, okay, and the client in my case. And we are a part of the team because we don't replace, obviously, your medical practitioners, but we're here to support you in your education process. And for, many of the women we see are dealing with trauma. And when we see how they're very symptomatic, right? I'll give you an example. I had a case last week, and this woman was basically hemorrhaging every month. And she had heavy periods, which we'll talk about also as being a vital sign of things going wrong. She had heavy periods since she was a young girl. Very, like to the point where they were putting her on birth control, I think she was like 15. And very, very painful, very heavy bleeding. And I started to ask her, let's look at what was going on in your childhood during that time. And what we found is that she actually communicated that she had been molested as a child, and she dealt with sexual violations over more and more. And so when we looked at the trauma in her life and how it was showing up in her physical body, we could trace why she was physically affected the way she was, right? So we don't just look at, okay, what are the symptoms you're dealing with? Because we try to deal with the root cause, what's going on in your life, whether it's spiritual, emotional, physical, that is affecting your whole life. So that's how we trace back. And specifically, it's when we say the community is helping them to feel, I like to say, I'm team, let's say it's Dr. Myers, I'm team Dr. Myers, because what I find with our Black women and our which are most of our clients, is that we put everybody else at the top of our list and we don't know how to prioritize our healing, okay? And healing, we believe, comes from the inside out, meaning the way we think about ourselves, what we believe about ourselves, and then how we treat ourselves, our self-care and our self-care practices that that are manifested in the way we eat, the relationships that we keep. My company is called Detox Living because we help people to live life free of toxic thoughts, people, habits, and foods. And what we find when we help people do that, they're able to experience major reversals in terms of their symptoms, major healing in terms of whether it's coming off high blood pressure meds. We had a client she lives here in New York. She actually she eliminated 50 fibroids naturally. People always say, what? Naturally, through diet, exercise, through herbal supplements of our balance program. Why? Because we dealt with the root causes of her emotional health, her mental health, as well as what she was putting into her body. Now, how I became a health coach was specifically, there's training to become a health coach. There's the integrated, there's INN, there are a lot of, right now, there's so many programs, online programs. If you just Google health coaching, specifically, you'll find many programs, but you want to look at what's for you. Some people, their focus is more maybe fitness balance, or it could be yoga balance, or anchored, excuse me. Mine was more nutritional and spiritual practices in terms of breathing and meditation and having healthy boundaries. Again, so when I come back to Black women, remember I said, usually they put everybody else first. And the only way healing is going to happen in your life is if you first know how to center your own healing. And that means eradicating or distancing or shifting those things that are toxic and actually draining and causing you dis-ease.
Thank you, Doctor. Thank you, Coach Jessie. I'd just like to read a comment from Shantana Hazel. She said, hi, everyone. I've had endometriosis for over 44 years and a health advocate for over 11 years. These conversations are necessary, especially for the Black and Brown community, to get educated on conditions that affect us at higher rates. That's a powerful statement and necessary. It's true.
So Coach Jessie, can you give us maybe a success story of someone who's used endometriosis?
Sure. Well, you want specifically endometriosis? Okay. So one of our clients is Yandy Smith from Love and Hip Hop. Her sister was battling fibroids and endometriosis for many years. And Yandy just learned about my work, and she said, listen, I need you to help my sister. And together, we started our detox. I think it was the year before last. And by day 13 on our program, which again is the coaching, so the empowerment, the accountability, the support, the education around what foods are inflammatory, what foods are estrogenic, because while there aren't a lot of studies that directly say root causes to these conditions, there's a lot of research that points to hormonal imbalance, vitamin D hormonal imbalance, estrogen dominance specifically being at the root of these situations. And that's our approach. All right. And when we tackle it that way, by day 13, she was like, and this is a woman, her testimony in full is on our website at thedetoxnow.com. You can look it up in the testimonials, and she speaks about it on an interview on the Breakfast Club. She said how she never thought she could live without pain. She never thought it was possible. And how she saw for the first time that she could live literally free of pain. By day 13, she no longer had pain that literally, not only was it her endometriosis, her reproductive pain, meaning her cycles, the cramping, the bleeding had shifted, where she was bleeding like every 20 minutes. She had to change her pads, to now it was like hours, she was fine. But then specifically, she had even pain, tendonitis. She had tendonitis. No, it wasn't tendonitis. I forgot, a rotator cuff injury. And it was so severe that she would literally cry herself to sleep. And because she was attacking inflammation at the root of her body in terms of the protocols, because she was just attacking inflammation, that inflammation that was in her shoulder finally actually was reversed to where she no longer had that pain either. So we know, I'm a woman of faith, and I really believe the body it was designed to heal itself. Science shows you the body knows how to heal itself. And I really believe that once we learn how to cooperate with the healing process, I see it all the time, that healing manifests. But we have to take the steps and get the support that we need to center our healing. And that means make sure that anything that actually drains us, I like to say, if it doesn't support your healing, you need to either distance it or cut it off. Right. And that's, again, the way we think about ourselves. We have to help women retrain their thinking in terms of believing that they're enough. When I look at why Black women are systemically disproportionately affected by these conditions, the one thing that comes up in all of our conversations, in all of my sessions, is that we are disproportionately affected by the trauma of racism and the stress, which is an upregulator of whatever stimulus you're dealing with. So when we look at the stress that Black women carry at disproportionate levels all the time, and we tackle that, it totally changes everything else. So instead of women feeling like, oh my God, I'm not enough, I'm having to prove that I'm enough all the time, whether it's in the workforce, dealing with microaggressions, to relationships, to whatever it may be, where you find yourself having to prove, you have to work 10 times harder to prove that you belong, that you have a seat at the table. That does something to you emotionally, physically, spiritually, in a way that it undermines your own belief in yourself. It undermines your internal peace. And that causes a level of constant inflammatory level that we're working around, because we're constantly dealing with radical stressors.
Right. And you talk about inflammation. And I think for our listeners, a lot of people are not sure what you mean when you say inflammatory diet and what is that you're referring to in terms of inflammation. So can you just describe that?
Sure. So think about it this way. So when 2014 was a very stressful year for me. It was, well, first of all, inflammation specifically occurs when take a stimulus of stress like cortisol. Cortisol is actually a chemical reaction. Okay. It's a chemical reaction that causes then your adrenals and then it causes your the narrowing, like the inflammation can occur in many areas of your body. Okay. All over. You can have inflammation of your neurotransmitters that causes specific mental health disorders, or inflammation in reproductive organs, and wherever that's happening, it causes disease. All right. When I had the hardest year of my life, one of the hardest until now, really last year, was 2014. And all things being the same, meaning my diet was the same, my environment was the same, my stress levels were off the charts. That year, my fibroids tripled in size. Why? Because stress is what we call an upregulator. And an upregulator, it literally multiplies the impact of the stimulus. So that's really our approach.
Thank you. I appreciate that. So we focused on a couple of things that can cause infertility in terms of there's to cause structural abnormalities, but we know that there are other things that can cause infertility. So just take a step back. I should have said earlier, I meant to mention that what exactly infertility is. So infertility is when a woman can't get pregnant after actively trying to conceive for 12 months. And I know that I'm an endocrinologist, not a reproductive endocrinologist, but I have women who come to me saying, oh, I've been trying. And then when you ask, well, how many times have you and your husband had intercourse? Oh, just once. So I'm going to first pass this off to Dr. Thompson. Can you describe what infertility is and what is enough when it comes to a man and a woman trying to conceive? Because I think that people think it's bam on the day of ovulation and that's all I have to do. So can you break that down for us?
Oh yeah,
thank you.
I'd love to break it down for you. So you're right. Infertility is a year of attempting to conceive. Doesn't exactly have to be timed intercourse, but ideally, and I'll talk to you guys about that a little bit more, but at least regular intercourse, right? But in women over 35, I cannot emphasize this enough, it's 6 months of trying. So at 6 months, you really should be starting to investigate what's going on. I think we really don't understand the menstrual cycle, to be quite honest, because we're always taught how to not get pregnant, right? We're not taught how to get pregnant and how our menstrual cycle works with that. Especially many of us do have irregular menstrual cycles due to things like PCOS. Even sometimes the fibroids can cause bleeding in between menstrual cycles, right? So it can be difficult for us to maintain a regular menstrual cycle. But essentially what happens in the cycle is we start to grow an egg. And this egg is stimulated by something called follicle stimulating hormone, which is important when we start to do an infertility workup. Follicle stimulating hormone tells our egg, one of our little many resting eggs, it picks one of them to grow and mature and get ready to ovulate. And then after you have intercourse, that egg should fertilize, and then it makes an embryo, and the embryo should implant and you should get pregnant, right? That's what should ideally happen. So for a woman, just for example, who has a 28-day menstrual cycle, that ovulation should be right in the middle of the month at 14 days, because the second part of the menstrual cycle should always be the same. It's something called the luteal phase. And just, you know, some important pearls about that is that the sperm should always be there to meet the egg. So sperm can live in the genital tract for a longer period of time, but the egg can only live for 24 hours. So if you think about it, you have such a short window of time to actually get pregnant. To your point, yes, we had sex once, right? Doesn't always cut it. And as we get older, it gets much more difficult to become pregnant. And I think we also have this misconception that most people are going to get pregnant in the first 1, 2, or 3 months. That's really not the majority of people, especially once you get into your 30s. The highest pregnancy rate we can ever say with natural fertility is probably when you're about 18, which is probably about 35% per menstrual cycle that you try. And it drops down to about 15% per cycle when you get to age 35, about 5% per cycle when you get to age 40. So it really is a dramatic decline in your chances of getting pregnant. And then when we talk about causes of infertility, I do want to go back to the fact that not all fibroids are created equal. You know, in the fertility world, the least amount of uterine manipulation that is done is best. And, you know, if the fibroid is in an area that is impacting implantation, which is usually on the inside of the uterus, then we generally do end up removing that. And again, you should always consult with your doctor. If you're not sure, it doesn't feel right, get a second opinion, get a third opinion. You know, you have to be an advocate for your own care, and make sure that you do have that comfort and that you don't have that stress gut reaction, right, that Coach Jessie was talking about. So, you know, it's really important to be a partner in your care. So those fibroids, if they're on the outside, may or may not impact you, but it also depends on your symptoms. So again, it is so personal. Endometriosis is one of the most difficult things to deal with in infertility. And I'm sure Dr. Jackson, they will definitely agree with me there. It is a challenge. And that's why it's so important that Black women who are already coming to us later in their lives because of the lack of knowledge and access, because there's this traditional thinking that Black women are just hyper fertile and we get pregnant like this, that, you know, the endometriosis has grown and grown and grown and grown. And now we're dealing with things like blocked fallopian tubes when it comes to your anatomy, cyst on your ovaries, and in general inflammation. And I'm so happy you addressed that, because I am a firm believer that inflammation can definitely cause an issue with egg quality and implantation. And we address that, you know, in our practice quite a bit. So, you know, those are the anatomic things. Other reasons women don't get pregnant are mostly age related. You know, once you get to 35, it gets to be difficult. Male factor, about 30 to 40% of infertility. Very difficult, you know, for men, and often very difficult for Black and brown men to think that they are a partner in this diagnosis. So it's really important that the guy get checked out. A lot of women will come to me and say, well, I'm going to bring him in a few months after I figure out what's going on with me. Absolutely not. Because yeah, I said, both of you guys were going to get you started at the same time, because it could easily just be purely on his end as well, right? So important to do all this workup concurrently. So the main issues that cause infertility are age-related infertility. Some women will have a premature decline in their fertility, and we can work that up as well as anatomic factors and male factor.
Okay, I think I could piggyback on what Dr. Thompson was saying, and I'd just like to say that Dr. Jackson Bay is on the call right now, so we're also happy to have her. I'm so glad that you touched on fertility after like the age of 45, because that has been a usual debate among my friends. I especially have friends who are 45 and over, 40, 45. And in my family, I know that I've had family members who've had fibroids and have had babies at the age of 42, 43. So for me, it's not very uncommon to hear that somebody in their 40s have had children. But for others, they're just like, oh, I'm 35, it's going downhill from there.
Right.
So I kind of want you to touch on that a little. And what if we are fertile? So I recently went to the doctor and had, I don't know the name of the test, but it was just a fertility test to see where I'm at, because I'm nearing that age, to see where I'm at. And so I just want you to touch on that a little. And also, I really like the fact that you said about, like, before I say that, my question is, can you be fertile after the age of 45? Like, can you still have a baby after the age of 45 when you're in your 40s? And the other thing is, how do we loop our men into having the conversation? Because usually when we hear about fertility, then men are usually like, my sperms are working well. It's you who have the problem. So just touch on that, both you and Dr. Jackson.
Okay, I'll start off and then I'll turn it over to Dr. Jackson Bay. Welcome, it's good to see you. You've got a couple of questions you have in there. Let me start with, can you get pregnant after the age of 35? 100%. Absolutely. Absolutely. You might need a little help when you get into your later 30s and early 40s. But yes, okay, there's no such thing as not being able to get pregnant. No such thing until you reach menopause. So when people come into my office and they're like, so-and-so told me I'll never get pregnant, that does not exist, okay? So even if you have a 1% chance, you can get pregnant. I also want to address the concept of women having children, especially historically later on in their early 40s. It's more uncommon, but also remember that, we, I think as Black and brown people have an earlier age of childbirth and may tend to, in those past generations, you may see somebody having their 6th or 7th child, when they're in their early 40s. It's going to be more difficult to conceive your first child when you get into your early 40s. And there are some various theories, behind that. But yeah, the possibility is always there. But the key is have the conversation. Because, get the work up, get what you need to get done, because it does get to be too late. It really does. After 45, conception with your own eggs is a less than 1% chance, so after that, though, we can also think about alternate ways of family building, like using an egg donor. And as a community, we need to be more open to these things. So, there's no absolute, no, you won't get pregnant. And how do we loop the guys in? Oh my gosh. And, we loop the guys in by, I think, just maybe showing them some data, bringing them in to talk to a doctor they trust. And I think that's super important, because I find that, the men and just in my consults, you have to draw them out, right? You have to be able to talk to them, and you don't want to play a blame game on anyone. We all have enough stressors and microaggression, especially as Black and brown people and as Black and brown men, so the key is to make them comfortable and just have a well-rounded conversation with them. And, for me in my practice, I'm happy to give the guys a call and chat with them at any time separately too. I think that's really important. We also need more mental health professionals who are used to dealing with reproductive issues in our communities.
Okay, so I think that brings up a really good point. Before Maya came on, she said she had one question, but she had 5 in one, about egg freezing. Because I think a lot of our Caucasian female colleagues are participating in egg freezing, but I don't think that we as women of color are really doing it. So Dr. Jackson Bay, for those of us who are career women, like all of us here, who think that we want to have kids later in life, what are some of the options for freezing eggs? Is it too late? Once you hit 35, can you talk about what egg freezing is, how we can do it, and who would be a good candidate?
Yes, so thank you guys for having me, and sorry for joining a little later. I think this brings up so many good points, and I'm happy to answer any questions regarding what we call fertility preservation. And so, just as Dr. Thompson mentioned, many women actually think they have more time than they do. And so these are some of the harsh realities of reproduction. I always like to say that our ovaries have not joined the women's lib movement. They are they are not about using your youth for education and for jobs and for advancement and for backpacking across Africa or Europe. They are on a stricter time clock. And so, yes, a lot of the data that we use is based on population level. There can be some variance. Some people have fertility that's more robust than we would expect for their age. Some people are going to have fertility that's actually decreased than what we would expect for their age. And so the only way you can really know that is to be seen and kind of start having these conversations, even if that's with your primary care physician, with your GYN, with your therapist, whoever you need to kind of start, kind of turning those wheels with. May even be with your girlfriends or coworker group, your sorors, just to know that there are options available and start, kind of destigmatizing it in that way. Fertility preservation via egg freezing usually involves, it's very similar to in vitro fertilization. And so what we would do is to give you injectable medications similar to the hormones that your body normally makes every month to kind of produce and mature an egg. But with egg preservation, we're trying to make as many as possible so that we don't have to do one egg per month. And so you would take medications typically from about maybe 10 to 12 days. During that time, you'd be seen for physician visits, typically early in the morning, so that you can do the visits and, maybe go to work or get your day started after that. But it's important to be able to kind of have that time to allot, because as you're taking the injectable medications, we want to make sure that your hormone levels are rising in an appropriate way, make sure that, your follicles are responding to the medication not too quickly or too slowly. And so it's about a 2-week commitment, I would say, during that time. And then as the follicles mature, once they get to a critical size, we're able to extract the eggs from your ovaries with a procedure that we do. It's no incisions on the belly. It's all through the vagina, very similar to the ultrasounds that we use. We can use the ultrasounds to see where the eggs are growing. We can't actually see the eggs, but we can see the fluid that they create as they grow. And so we'll use a very small vacuum to aspirate the fluid, give it to the embryologist. They look under a microscope and they're able to actually count the eggs. And so in that way, we're able to freeze the eggs that day. And potentially, if you ever had to use them in the future to create embryos for your family, your reproductive potential should be around the age at which you froze the eggs. So if you do this at age 25, but you don't use your eggs until maybe 35, your chances of successful pregnancy should be around that of a 25-year-old. And that's why we call this fertility preservation, because it's really one of the only ways that we have to kind of stop the clock in a sense. There's, no amount of amazingly healthy lifestyle or Peloton biking or vitamin supplementations is going to keep your ovaries at age 25 or 30. You're only as, today is as young as you'll ever be. And so, this is one of the few options that we have to kind of stop that clock in a way. And so, this brings up a really good point about who's using this technology. For a long time, we actually only used this for extreme circumstances, women who were going to undergo cancer treatment that was going to completely really destroy their egg producing capacity. And so this was seen as something that was experimental. In 2012, we actually lifted the ban of this experimental title and said, no, the technology has advanced so much that we feel that this should be available to anyone who wants it. And so since that time, we've seen an exponential increase in women who are freezing their eggs. There are different titles on it, whether it's elective or social. I think it can be seen as, a normal, what we call family planning adjunct. The same way that you take contraception when you're young to avoid pregnancy, this should be seen as an extension of that, to freeze your eggs so that you can have more time to have the family you want when you want. It doesn't mean that it's 100% guarantee and that you can kind of put all of your eggs in one basket per se, but it is, it can be a really good option for women who are, looking to further their careers, who are not in the relationship that they want right now, who maybe are starting their families later, but know that they want more than one kid. And so maybe this might be a way to access this reproductive potential at a later time. there have been some studies that show that, women of color across the board are not using this technology as much. I think there could be some big barriers there. One is just knowledge. We tend to do things that our peers do. And so if no one in your peer group has ever done this, or, isn't celebrating it or supporting it, then it's not even on your radar. Another thing is it's not commonly covered by health insurance. Again, because violence against women's health in so many different ways. Even infertility treatment isn't covered in many places around the country. And so, unfortunately, freezing eggs just to be able to delay childbearing is still seen as somewhat elective, and it's not commonly covered by insurance. There are some insurance carriers who do, and there are some employers who want to be able to have this benefit for their employees. And even within those companies, we still see these disparities. And so I'm really trying to understand and work with some groups to say that, are we promoting it in the same way? Your employees have this benefit, but they may not be using it. Why would that be? It can be expensive. It's, like a lot of other things that we do, it's a sacrifice, like taking out loans to go to college, or, moving into that tiny apartment so you can take a nicer job or something like that. And so I really, try not to let the cost, to completely take it off the table as an option, but just to rather think about it into how it could work within your whole life plan. And yes, talk to your family, talk to your friends. I always say your parents may be willing to finance it because this could potentially be their source of grandchildren in the future. So don't sell yourself short just because it sounds expensive. It could be a huge help to your overall fertility plan.
Thank you. And then as a follow-up, can you, either you or Dr. Thompson explain the difference between egg freezing and in vitro fertilization? Because both of them can be relatively expensive, and the expense comes from the medications, the co-pays, the seeing the doctor, the cost of the procedure for removing the eggs, the possible genetic testing. So could you also explain what the difference is between just doing egg freezing as opposed to in vitro fertilization?
So egg freezing and in vitro fertilization are essentially the same thing. I like to tell patients that it's just broken up into different sections. The process of taking the injections to retrieve the eggs, if you're egg freezing, then your journey stops there. It stops the day that we kind of remove the eggs and freeze them that same day. For persons who are looking to become pregnant either at that time or sometime in the near future, or if they're with a partner, once the eggs are retrieved, they can be inseminated that same day. And then that process of growing embryos in a lab takes a few days. And then we may be able to test the embryos to make sure that they're chromosomally normal and have the normal number of chromosomes and not too few or too many. And then we can transfer the embryos back into the uterus for pregnancy. And that can happen immediately, or it can happen at a point in the future. And so some persons, for fertility preservation, may choose to go that route if they're either in a relationship or would like to use sperm from a donor. They may choose to create embryos to freeze and save those embryos as another route of fertility preservation. And so, egg freezing and in vitro fertilization are actually very similar. It's just the cut points of when you stop care and when you may resume later on. When you want to use your eggs or embryos in the future, you're not doing in vitro fertilization again. The process is kind of like picking up from where you left off. So if you freeze eggs and you would like to use those eggs in the future, you would contact your fertility provider. We would thaw those eggs, inseminate them, and then grow the embryos in the lab. So it still is going to be that same process of making the embryos outside of your body and then placing them back, usually one at a time. If you're doing in vitro fertilization, they may just have the embryos frozen and you could come back for them as you need them.
So I'm going to get to the $1 million question. I'm going to pose it to both you, Dr. Thompson, and you, Dr. Jackson-Bey. Both the Society for Reproductive Medicine as well as the American College of Obstetrics and Gynecology have recommended that women get the vaccine, as it should not affect or impair their fertility. So I would just hope that both of you can comment. So first, Dr. Thompson and Dr. Jackson-Bey, on what your recommendations would be.
Okay, great. So you're exactly right that ASRM, ACOG, the Society for High Risk Obstetrics, SMFM have all come down and said that women who are trying to conceive and women who are pregnant should be offered the COVID vaccine. So, obviously anyone is taking any medical treatment at their own risk, right, in terms of the vaccine. But you should recognize that all of the benefits outweigh the risk. And there's nothing about these vaccines that should impact fertility or a pregnant woman at all. There's truly nothing. I know there's concern because pregnant women were not studied in the trials and they're for emergency use, but the mechanism of action of both of these vaccines, and you may have gone over this at some point, in your COVID series, but the mRNA vaccines, actually will create a messenger so that a protein is formed to make antibodies to COVID-19, both through all the vaccines, Pfizer, Moderna. J&J has a little bit different mechanism using an adenovirus, but the concept is the same, that it will promote antibodies, which will fight off COVID-19 should you get it. None of them are going to change your DNA. Right, none of them are going to change anything with your gametes, your sperm, or your eggs. So, I'm a staunch advocate for getting the vaccine, and I think that I loved the article that you posted earlier. I really think it's not really vaccine hesitancy, but access in our communities so far.
Yes, I wholeheartedly agree. There's just so much concern and mistrust. And I think that's actually, it's rightfully so. Our country doesn't have a great track record of transparency and honesty around, reproductive care and around healthcare for Black and Brown people in general. And so I think some of the hesitancy initially was about just how fast the vaccine was developed. But agreed, the way in which this vaccine is delivered, at least the mRNAs, there's no reason for us to think that it integrates yourself into the DNA, that it would change our own DNA. I like to tell patients that it's kind of like a Snapchat. Like you can see it for a short time, your body's going to make antibodies to it, and then it completely goes away. And so it doesn't hang around in any way that we understand so far. And so that it should give you a little bit more assurance. But, I do understand the vaccine hesitancy and just trying to be as sensitive as we can around this and continue to just educate as much as possible to get as many people vaccinated as possible. Because again, we're still seeing people infected, even within, my community and workspaces and stories, still hearing of people coming down with the infection of COVID-19. And so anything that we can do to prevent that, we want to encourage people to do all that they can. And that includes women who are pregnant, breastfeeding, lactating, or thinking about becoming pregnant. We actually are encouraging them, if they feel comfortable and they're eligible, to be vaccinated.
I just want to add to that too, when I mentioned that the benefits definitely outweigh the risk. If you were to become ill with COVID-19 and you're pregnant, you're going to be at a higher risk of miscarriage, preterm delivery, stillbirth, similar to if you had the flu when you were pregnant, right? So very important to try and mitigate those risks. As opposed to a very small risk of generally, fatigue, perhaps a mild fever when you do get the vaccine.
And of those conditions, even ICU admissions, needing special kind of lung support, ventilation, even ECMO, and death. Those are the ones that came out of the CDC report of, the increased risk for pregnant women with COVID. But again, Black women were on top, and their risk for all of these things were higher than the other women in the study. And so, even more reason for us to kind of encourage amongst ourselves and amongst our patients, because again, these disparities persist in COVID-19 with pregnant women.
One more thing about COVID-19, there was actually a recent study that maybe one of the first babies from a mom who had the COVID vaccine had antibodies. So protection for your child as well looks like, at least just like with any other vaccine, in the first 6 months and you're getting those antibodies, at least to possibly get us through this pandemic, will ensure a healthy mom and baby.
Thank you so much. This was a very, very interesting conversation. And we do have one question in the chat, but I'm not sure that we have time to ask it. So I'll just close. We've just put in a plug and I'll share my screen, just to put in a plug for our next event, which is going to be on April 1st. And this one is very dear to my heart because it's talking about immigrants, a population that's not very widely spoken about in the COVID-19 or the fight for COVID-19. But as we know, there are a number of immigrants who are on the front line fighting, whether that be grocery, there are many essential workers who are indeed immigrants, and yet still they're not in the conversation. So we'd like to have this conversation just to talk about what the immigrants' rights are, what you could do as an immigrant if you're undocumented, where you could go to get the vaccine, and that sort of thing. So join us at the same time, same place, April 1st at 8 p.m. for us to be talking about the COVID-19 conversation, for us to be talking about immigrants and COVID-19. And so I would like to continue by saying that fibroids is so common in Black communities, especially for Black women, but it is often not spoken about because sometimes we do not know, or we do not understand the process. We do not understand fibroids. Not all fibroids are created equal. So even though you're 20, you should have the conversation with your gynecologist about fibroids and what to do, what not to do. I know there are sometimes some doctors will say, oh, your fibroids is small, you don't have to worry about it. And the next thing you know, it has grown and gotten really, really big. Endometriosis is another often not spoken about topic in the Black and Brown communities. And it's also undiagnosed because before it was typically considered a white women disease. But we're seeing that more and more Black women are actually having endometriosis. We heard from Coach Jesse, who was talking about what it is to be a health coach. And a health coach is basically there to help you along with your health journey. They try to look for the root causes, such as mental, spiritual, the trauma that we've had in the past. As Black women, we tend to support everybody else but ourselves. And we do have to deal with a lot of racial trauma that sometimes affects our body. And so her company, the Detox Now, will help individuals recognize this trauma and work towards eliminating it. The body knows how to heal itself. Science has taught us that. And so we could use our body to heal ourselves. Infertility, a lot of women try twice and they're just like, okay, I give up, I'm infertile. But usually it takes about a year of consistently trying, and over 45, it's like 6 months of trying. So you have the conversation, then you bring along your partner, you talk about it, you involve your partner as much as possible. It is not one person having a baby. We're not having the baby for the woman, we're having the baby for both the man and the woman. And there is this misconception that we cannot get pregnant over 35. We can get pregnant. It does get a little tougher. I actually liked the fact that Dr. Thompson did say that pregnancy actually stops at menopause. So you can get pregnant at 35. At 45, there is conception, but with your own egg, it's like a 1% chance. So you might just have to talk to your doctor a little bit more about that. We spoke about freezing our eggs. That was quite an interesting process that I didn't know much about, and it was very helpful to know about it, where you could just freeze your eggs. If you freeze your egg at 25, then when you're ready to have a baby, it's like you're 25 again. So your body is healthy at that point in time, then you could actually use the eggs. Most importantly, we also spoke about the COVID-19 vaccine. As Dr. Thompson mentioned, there was today an article that came out where a woman, she was pregnant, she did take the vaccine. I believe it was the Moderna vaccine, and her baby did have the antibodies. So it is safe for you to take for you to take the vaccine. If you are uncomfortable, have a conversation with your gynecologist, have a conversation with your health provider, and see whether or not you can have the vaccine. I think there are a couple of comments in the chat, so I'll just read that as we have 1 more minute. It says we do not, somebody asked a question. It was mentioned about RNA proteins and vaccines. What's the implications of this when it comes to immune responses? Dr. Thompson said we don't quite know yet. We may need a booster or yearly shot like the flu. Not a question from DK, who said not a question, just a thought. I'm so happy these conversations are available to join. I noticed many of the attendees are within our communities. Are there any stats on conference important for everyone? How can white providers help the Black and brown patients if these topics are not mandatory? This is why we created the COVID-19 conversation so that we could empower Black and brown people to advocate for themselves. We could educate them and give them the necessary information that they need so that they could go and talk to the doctors and say, hey, here's what I want to talk about. You know, advocate for yourself. As we had a rheumatologist on last week, 2 weeks ago, and there are only 8 African Americans of a recent study who are rheumatologists. We are most likely to be affected, but at the same time, we are least likely to have doctors who look and sound like us. So advocate for yourself, ask the correct questions, do the research as much as possible. And for me, I did a total revamp on my health where my entire medical team is Black women. It was hard getting, I worked very hard to get it, but eventually I did get it. So our next show is on April 1st, 8 p.m. It's on immigration. Thank you so much to our lovely panelists. This was great. We will see you next time. Have a wonderful evening.
And catch us on YouTube if you want to catch it again.
Yes. Thank you for having us.
You too.
Have a
Thank
good
you.
night. Thank you so much.
Thank you.
Good night, everyone.
Don't forget to follow us on Instagram and on Twitter as well.
Yes.
Great.
All right. Bye, everyone.
Thank you. Good night.